get started with Dr. Meena. Meena is a senior faculty member at Shankar Nethralaya, Chennai. She'll be highlighting a cornea plana.
Good morning, everybody. It's always a pleasure to be a part of IC of Dr. Muralidhar, and I will share some of the pearls or what I have learned about Cornea Plana. So Cornea Plana, incidentally, has been existing even before the term sclerocornea was described. It was described as early as 1912 by Rubel in 3 siblings. But it was in the year 1935 by a publication of 3 authors who highlighted the entire spectrum of cornea plana. As of now, it is now described as a primary corneal opacity, and in the recent classification by Ken Nishan et al., it is a primary corneal disease. Its rare prevalence, or rather prevalence is not known. It's described as a bilateral and so far non-progressive. It is for years to tell now whether it was slowly progressive. The OMIM classification has divided this into autosomal dominant and autosomal recessive types, where the autosomal dominant variety in the large population is described to be less severe, and the more severe, the autosomal recessive, is found to be more severe. What the Finnish and the Saudi Arabian groups have done is they have described these lesions and they have mapped this mutation on the long arm of chromosome 12 of the KERA gene, whereas for the autosomal dominant, the mutation is yet to be identified. The mutation lies on the keratin sulfate proteoglycan, which is a protein which is needed to maintain the interfibrillary distance in the cornea. This particular protein is prevalent particularly only in the cornea. In the mice which are null to keratoconine, they have been found to develop thinner corneas with shallower anterior chamber with faint opacities. It is seemed to occur somewhere at the 12th week of gestation, this kind of aberration. So we come to this child which came to me. She was an 8-year-old child who parents said that she was progressively having low vision, and her chart was very, very unique in that it was when I went through the chart, I saw the number of diagnoses that I could make out. She was diagnosed initially with ptosis with macular opacity, henceforth with microphthalmus with convergent squint. Somebody had even mentioned that she had endothelial dystrophy. In the following up years, in different centers, she was diagnosed as Peters anomaly and flat cornea, and she was planned for examination under anesthesia for a glaucoma assessment. And there and henceforth, she was not compliant to occlusion therapy and she maintained a low vision. Somebody had also mentioned limbitis and started the patient on anti-allergic medications. And finally, in 2022, prior to coming to us, somebody had managed to make a diagnosis of anterior segment dysgenesis with dyschorhea and fundal coloboma. So we'll come back to this case later. So I come to this child, case number 1, a patient, a male child born of non-consanguineous marriage. Patient noticed his uniqueness in having low vision and having disturbance in vision for distance and near. This was a referral from the pediatric ophthalmologist. So as a cornea specialist, I rarely see cornea plana directly, but my pediatric ophthal colleagues are very nice and send me these patients because I have educated them well enough how to pick up these cases. So this child, although had very high hyperopia, was found to have was not corrected initially, had nystagmus, gross stereopsis was poor, and the pediatrician, the pediatric ophthalmologist, was astute to pick up the different in the contour of the cornea. So all he could just say was it looks oval shaped. So if you see the frontal picture of both the corneas, you would see that these are very prominent arcus, such that even though the cornea appears flat, the Vokes limbal palisades have overtaken the flatness and become more prominent. On the side profile, if you see, we have to lift up the child's lid, showing that there could be mild ptosis here because there is the curvature of the cornea is similar to that of the sclera, so the lid is almost falling onto the cornea. In the lower picture, you will see that there is a faint opacity in the midstromal part of the cornea. We were able to image him and we could see high hyperopia, and the pachymetry was not too thin. It was seen to be around 500. Case 2 was a female child which we had seen in 2015 with similar presence of high hyperopia, and with the pediatric ophthalmologist noticing a faint opacity, assuming that these are patients of Peters anomaly and where we would want to jump in and do surgery. And the patient was non-compliant to patching and had poor vision. And subsequently, we were able to see her from 2015 to 2018. She maintained the flat curvature of the cornea, and the pachymetry also similarly remained around 700 microns. The same child was seen around 4.5 years later, where there is so much resistance to patching and the vision keeps dropping down, and here there is dense nystagmus and the child develops a face turn. And you will see by the time the child was 7.5 years, she was referred to the low vision clinic. So you will see the temporal association of these children where the vision is slowly deteriorating despite the intervention by the ophthalmologist. And this is the characteristic phenotype of these pictures, where there is a lipoid-like infiltrates of the peripheral limbus, whereas the central cornea is just faintly hazy, and the corneal diameter appears less, like much so like a microcornea. And then this is case 2. Okay. Case number 3 is a child which we saw after some intervention because they were not able to pick up the cornea plana. Had already undergone optical iridectomy in the right eye, and when we saw in the left eye, this child presented with hyperopia and some kind of milder lower axial length. So there could be some variation because the right eye was intervened early. Maybe it was not picked up, but we were able to pick up the cornea plana because of the central macular-like opacity in the center of the cornea here. So it's very important to undergo to educate the parents about the need for genetic counseling and genetic screening, and we found that this patient actually had undergone genetic analysis. So case number 4 is also a long history of a decade. The father had brought this female child who wanted to bring this child because the eyes were looking small. He was very worried. And we followed it up between 2017 to 22, where the lower pictures you will see that the pachymetry has predominantly remained the same. Now, if you see the specular in these children, the numbers don't really actually are not very different, but they may vary. The coefficient of variation may be slightly higher. And in case number 5, in these children of where there was similar episode both in the sister and the brother, you will see this flat kind of cornea. It's very clear cornea, that much that you are able to image the specular microscopy is what I want to say. So always go ahead and take the specular microscopy when possible. But you will find that if the number doesn't vary much, the coefficient of variation may be higher. So again, between 2017 and 23, you will see the stability in the Kmax and pachymetry. There's not much change. That's why at present it is still not a condition which is described as a increase progressive in nature. So this is the photographs of the patient seen in 2017 and 18, where you'll see microcornea, dense arcus-like, and central macular opacity. His younger sister also presented noticing at a very young age, at the age of 1 year, where there is hyperopia and decreased vision. And if you see in her, you would see the typical disc-like features showing the thickening of the midstroma. And in the posterior iris, posterior cornea, the iris pigment was attached. The specular microscopy grossly looks normal, but a follow-up will be needed to know whether there will be really a change or stability in these cases. So this is how the OCT looks like. There is mid-peripheral thickening of the cornea. At the ends of this thickening, which is described as a plaque, there is a thinning of the cornea. And this is almost the case in most of the patients in which you would classically see the disc-like opacity in the slit lamp. In those patients where you don't see the disc-like opacity, this will not be seen. So again, there is hyperopia and there is low pachymetry. So another patient that we saw, it's not, so we saw a child where there is two children where the two brothers were affected, one sister and brother were affected. This was a family in which a 4-year-old child was affected like this, as you can see the picture, and the mother also had a similar picture, showing that maybe we have autosomal dominant in our Indian scenario. So the OMIM classification, which has divided this as autosomal dominant and autosomal recessive, typically describes this as a less severe and more severe, where the more severe, the autosomal recessive, is associated with mutations known to affect at the long arm of chromosome 12, iris abnormalities, maybe progressive edema, glaucoma, and ectasia, which is not very clear at this point in literature. And they may also be associated with longer axial length, meaning not only hyperopia, axial hyperopia, they are associated with myopia as well. And certain case reports of systemic hypotrichosis has been described. Typically, the keratometry of autosomal recessive is as low as 25 diopters, and the lowest diopter of an autosomal dominant is around 38 diopters. So if you see this chart, all those described countries described in red are those families in which autosomal recessive have been described by specific missense or non-missense mutations on the long arm of chromosome 12, especially from Finland and Saudi Arabia, where the genetics has been identified. And only anecdotal case reports have been described from the other countries which are described in white. And autosomal dominant pedigree will typically look like this, where there will be multiple generations affected, and autosomal recessive, where you can skip the generations and you can have a affection. So I've already described the role of AIOS20 is to look for the disc-like plaque and to look at iris adhesions when they're present and document them with AIOS20. And it's important to temporarily take specular microscopy, because they can be associated with decompensations and also show lower coefficient of variations. And most of them have been associated with normal axial length, but more so we need more data to see what is the actual axial length in these different geographical variations of this particular condition. So glaucoma, both open angle and angle closure glaucoma has been noted. That is why another important thing is to follow these children. And ectasia has also been noted. And rare conditions like duplication of the iris and associated of different mutations like PITX2 mutations with the same phenotype have been described. So the differential diagnosis are any other primary and secondary corneal disease, microcornea, microphthalmus, and nanophthalmus. So vision rehabilitation is very important. You have to identify the cause of high hypermetropia, treat the accommodative esotropia in these patients. Spectacle correction is very important. Contact lens fitting where and when possible, and treat the ametropic amblyopia, and look for rare corneal decompensation and glaucoma. Penetrating keratoplasty and cataract surgery may be included if these grow up into adults with good vision. Keratoplasty has almost never been ever described. The take-home message is we have now described a condition which is bilateral, symmetrical, mildly progressive maybe, with a known clinical features. Document as much as possible. Refer to the pediatric ophthalmologist for amblyopia therapy. Genetic counseling and testing are very important to identify newer gene mutations maybe, and long-term follow-up, especially for glaucoma management. And we come back to the first case where we saw, so when we saw the face of the child, you could see the beaked nose of the child, and we knew that we were probably not actually dealing with the case of cornea plana, whereas there could be overlap with other congenital corneal diseases. You can see the excavation as in described in Peters anomaly in this AIOS20. Thank you so much.